everybody. Thank you so much for your time this afternoon. We're all really pleased to be here. My name's Carrie-Anne Adams. I'm Head of Inclusion and Diversity here at Tokyo Marine Kiln. And I know you're expecting to meet our brilliant executive sponsor of our Menopause Network, Sue-Fen Lin, who is also a senior leader here at TMK, but she's unfortunately been pulled into an urgent last-minute meeting, so you've got me. But I'm really personally pleased to be here as well. I don't mind sharing with you, I'm a woman of perimenopausal age, and I've had some women's health issues that were written off as perimenopausal symptoms and not investigated early enough, and I resulted in having surgery, which really could have been avoided if I'd have known more about perimenopause and maybe known Lexie a little bit sooner. Most women experience menopause and are likely to experience it between the ages of 45 and 55. And so if they're working, they're likely to experience menopause at work. The impact of menopause is not solely experienced by the person going through menopause. It also impacts on our partners, our colleagues, and also our family. At TMK, we're really committed to growing our inclusive working culture and diverse workforce, and we're really interested for that reason to be doing this work in the menopause space, not just because it's the good and right thing to do, which it absolutely is, but also because research shows that when you have an inclusive working culture in which everybody can perform to their best in the workplace, this leads to better business results. We have an active menopause network here at Tokyo Marine Kiln. I'm really proud to be working with the menopause network that helped us introduce a menopause policy last year. And I'd like to say a big thank you to Tash, who is our current menopause network chair, and Mandy, our previous menopause network chair, who've really helped us drive the change and raise the profile and discussion around menopause at work. I'm really proud to be here with Lexie Minter, menopause specialist, who will be taking you through some slides shortly and talking to you more, and also with Palika, who works with me here at Tokyo Marine Kiln, who will be taking questions at the end. Before I hand over to Lexie, just so you know, Lexie will be showing you some slides which have a Slido code on. You can use that Slido code to submit your questions, which Palika will then take at the end as a bit of a Q&A with Lexie. So I'll hand you over to the brilliant Lexie now. Thanks very much.
Thank you so much, Carrie-Anne. It is really lovely to be here with you all today. And thank you to Tokyo Marine Kiln for sponsoring this. TMK has been one of the companies we've been working really closely with around their menopause care. And they've actually provided their employees with a first and follow-up appointment with our clinics, so we can actually provide good care for them. And it's been really great to work with those in Singapore just providing advice and guidance around the menopause as well. So, as they said, my name's Lexie Minter. I'm a menopause nurse. I have been a nurse for a very long time. I have to warn you, I have been an A&E nurse and a midwife in the past, and so I am not worried about anatomy at all. Just get used to the words vulva and vagina now. I've seen pretty much everything come in and go out of every part of the body. I now run a practice with a team of doctors and nurses to provide women's health clinics, and we see patients across the whole of the UK and in our virtual clinic, as well as in person at Lloyd's of London and a new clinic coming up in Chelmsford. So my brief today was to talk about the physical changes in the menopause, and I'm going to give you a medical overview on the subject, and Palika and I will look forward to the Q&A at the end. There's a Slido code, as Carrie-Anne mentioned, where you can just type in any questions and we'll go through them all at the end and answer them as much as we can. So a bit of the basics on the definitions first. The menopause is officially no menstrual cycle for a year, and quite an eventful 24 hours after that, you are then post-menopausal. Now, interesting, the average age of menopause does actually change from country to country, and in the UK and in the USA, it's about 51, much younger in India, average age of 56, and slightly older in Norway at the age of 53. And essentially what you've got in that graph to the right there is what happens in a normal menstrual cycle with those hormones ticking along each month. And then the key bit about the menopause is that actually those hormones, they drop down and they stay down. We're born with a finite amount of follicles, and when those follicles run out, we stop producing those hormones, hence that graph dropping off. So symptoms can start about 10 years before the menopause, and this is the part that we call the perimenopause. And women can have symptoms long after their actual 1 year without a menstrual cycle as well. And I think still a lot of confusion out there that people think they've got to wait for this magical 1 year without a cycle to seek help or to get any more advice or any treatment. But actually, we can look at providing advice and guidance long before the menopause and long after the menopause. Now, we'll also see some women having much younger menopause. So 1 in 100 women will have a menopause before the age of 40. And that's actually called a premature ovarian insufficiency. And some women, even under 30, will stop having their menstrual cycles and be menopausal. So this perimenopause, this is what I would describe the hormonal roller coaster. You've got those hormones ticking along really nicely on that graph. And then you've kind of got this perimenopausal transition where 1 month the hormones are working. It's like you're fully dressed, good to go. And then the next month, your hormones are not really working as they should do. And you and your hormones are in a onesie, a bit like those two pictures there. That's describing some of the variation of how you feel in the perimenopause. The key part about this, though, is that actually in that perimenopausal transition, those sort of average estrogen hormones are dropping down. And that will have an impact on how you're feeling. So I think a lot of people think it's an age-related thing, the menopause, and actually that's something we really need to kind of move away from. If we look at Angelina Jolie, for example, she had the BRCA gene, so she opted to have her ovaries removed, a hysterectomy, and a breast reduction, because that will reduce all of her risk factors around that BRCA gene. So that would have put her into a surgical menopause. We've got actress Kate Walsh. She found herself to be in a early menopause, that premature ovarian insufficiency, at the age of 39 when she found she was having infertility issues. And we've got Michelle Heaton there, the singer, who found that she actually went into a medically induced menopause following cervical cancer treatment. So there's lots of different reasons why women will go into menopause. Some of it will be what we call the natural age of menopause, but others may be medically or surgically induced. And there's some younger girls on that picture, because for some young girls, they may never start their periods. There can be some genetic conditions mean they never start their periods, and so they are actually in a premature menopause. And then the slightly older lady there, symptoms do continue for quite a long time in very different ways, but we need to think about the older population as well when we're thinking about symptoms and how to manage them. So it really does impact women of all ages. So this just covers a little bit about that kind of when that perimenopausal transition can be. Essentially, it can be at any point, depending on, because we never know when this magical 1 year without a menstrual cycle is going to be. And I think what's really key about this is if we look at that average age of menopause, it's really important to realise the average age of suicide in women is age 45 to 54. We really underestimate sometimes the emotional impact that some of these hormone changes can have in women. And I'm going to cover that a bit later. So how do we think the sort of actual symptoms are of menopause? I think most people think it's all about hot flushes, and if they're not having hot flushes, then it can't be hormones. But actually, when you see some of these symptoms popping up on this screen, you'll find it's probably about 40 symptoms that can be related to menopause. Now, some of them may be related to other conditions. So as clinicians, we're always going to try and rule that out. But some of the really common ones that I will see, and these are quite surprising to quite a few people, is often plantar fasciitis. That's that pain to the bottom of your feet when you first start walking in the morning, feels like you have to start wearing boring shoes. And, sometimes that's kind of that estrogen changes with that hormone fluctuations impacting muscles and tendons. Sometimes joint aches, worsening rage, not sleeping quite as well, just women not feeling themselves, feeling like they're falling apart sometimes. And this is not all women, everyone has a very different experience. Frozen shoulders, quite common, sort of tendinitis type things, quite sort of common in the perimenopausal transition. And then palpitations, either at night or at certain times in the cycle, increasing allergies, use the same skin products for years, suddenly reacting to them. Vaginal dryness, vaginal soreness, bladder issues, UTIs, urinary tract infections. So lots of different ways for those to impact in women. So hopefully you realise now it's not just about age or menstrual cycle changes. We can actually have regular cycles and the body's hormones not working quite as well and still producing symptoms. And it's certainly not just about hot flushes either. Now, what we're really not covering a lot when we're talking around hormones is actually some of the health implications that, yes, our hormones are declining, yes, they're changing. It can impact our mood, it can impact us physically, but there's some other health aspects which I think it's really important to share. So, for the first time in history, women are now living as long in their post-reproductive years as their reproductive years. So essentially, about 100 years ago, we dropped dead around the end of menopause, around 50. So this is the first time we're really seeing what the impact of this is on our long-term health. Now, women live longer than men, but we live in a much poorer state of health. And we're really well until we hit the menopause. And then post-menopausally, we seem to get a lot more illnesses and a lot more issues. And the lack of hormones have a huge impact physically, mentally, and emotionally. Now, when we look at the leading causes of death in women, this is for the UK. And the UK leading cause of death are cancers, actually, and the most common ones people think about are breast cancer, actually quite a small part of that. And then the next biggest killer in the UK is dementia and Alzheimer's, and then cardiovascular disease. Interesting, in the States, the biggest killer will be cardiovascular disease, slightly different populations there. And then when we look at that slide to the right, that's bones. And actually, what's quite interesting about women postmenopausally is once we don't have any estrogen, it stops that ability for the bones to regenerate. And so osteoporosis is a really preventable disease, but unfortunately still 1 in 2 women will get osteoporosis. And there's a lot more we can be doing around this. Estrogen regenerates our bones at any age, but also we know that without estrogen, women have more cardiovascular disease and more autoimmune disorders and diseases. And the reason I'm saying this to you, because actually we know if we replace some of those hormones, we can actually have a positive impact on some of these big killers in women. We don't know about Alzheimer's and dementia. The research is not there yet. The jury's very much out as to whether it will make any difference, but we've only just really started doing some great research in women's health. Bear in mind, we didn't actually start testing drugs in women until the late 1990s. We've still got a long way to go to get much better data. So I mentioned a bit that actually without estrogen, women have a 4-fold increase in cardiovascular disease. Estrogen does have a really positive impact on our blood vessels, keeping them really nice and elastic, and it has a positive impact on our good cholesterol. And the difficulty in women is that our cardiovascular disease is often under-recognised and missed. In men, the diagnostics are very well set up. Men tend to have bigger vessel cardiovascular disease. And so all the diagnostics and imaging will pick up that large vessel disease. But in women, we have much smaller vessel disease. And at the moment, our diagnostics are not hugely accurate in women's cardiovascular disease. And that's something we really need to address in healthcare. But this sort of impact of hormones on our cardiovascular health actually kind of explains why women postmenopausally tend to have more cardiovascular events and why our health is deteriorating somewhat without our hormones. So some of those other physical changes can be around menstrual health. I speak to a lot of women who unfortunately had years of flooding and heavy periods before they hit their menopause. And there's a real sense that women just have to put up with it. They have to put up with heavy periods, heavy bleeding, women going into meeting rooms and looking to see where they can sit down, checking the colours of the chairs. A lot of this is down to actually the hormone imbalance. And if we look at replacing those hormones, sometimes in those perimenopausal areas, or even looking at adding sort of progesterones, we can really help manage that bleeding. To me, anything that's life-limiting in women is unacceptable, and there's something we should be able to do around it. Which comes on to not sleeping, hot flushes, night sweats. Estrogen makes those go away very quickly. And actually, for those women who can't have estrogen, we do have some other alternatives as well that can really stop those debilitating symptoms. It's not something we just have to put up with and suffer. I think in previous generations, menopause was something that women just got through. And there's an element about feeling like one has to do it naturally or to suffer to some extent. But actually, there are a lot of things we can do to reduce these symptoms and make day-to-day life much better. I'm going to cover a lot more about vaginal dryness and urinary symptoms. I spend a lot of my time talking about vaginas. It's probably one of my favourite subjects, so we'll come back to that one. Lots of women not sleeping, and then when they're not sleeping, they're eating a lot the next day to try and keep the energy levels up. Then the body shape changes. Our bodies know we need to keep estrogen, even if we don't. It starts trying to store it around our middle, and so there's that kind of middle-age spread. And then we're going to get really quite anxious and, sort of depressed and not moving and not going out. And it's a whole cycle that actually can really impact, some women. And I'm saying some women because some people sail through this and they have no issues, but others really have a different variation of symptoms. And it's so individual as how people will experience this. We've talked about osteoporosis and the estrogen, we can regenerate our bones at any age. And actually, estrogen's really useful for the skin. It helps with our type 2 collagen and our faces and in our vaginal health. There'll be changes to breasts, as we expect with hormones, will have had it previously with contraception changes and pregnancies potentially. And then joints and muscle pains. There's a lot of aches and pains. And I think it's interesting when we look at all the different health services that are coming together, but lots of things get missed with that kind of tendonitis, plantar fasciitis, cramping, frozen shoulders, when presenting with hair loss, lots of different symptoms when we're presenting at healthcare all the time. And sometimes we just don't join the dots together and actually think this could be hormonal. I think this is possibly the worst statistic that I have to deal with in my line of work, that 70% of women will relate the onset of urinary incontinence to their final menstrual period. Now, this is because estrogen impacts the bladder, the urge to pass urine, and the mechanism to release urine. And unfortunately, due to all our adverts about urinary incontinence and pads, it's sort of normalised to women. But actually, urinary incontinence is not normal and not something women have to put up with. And there are a lot of things we can do around it, and a lot of different management strategies, hormonal, pelvic floor exercises. There's a huge amount. And again, I think this is something in a workspace we have to really think about, because actually access to toilets, access to changing facilities, this is something that can be really life impacting in women, but actually quite easy to fix and to manage. This is my favourite subject, vaginas. So when we're young, we've got lots of estrogen, which gives us our type 2 collagen in our face, our vaginas. I mentioned, so our vaginas are just ready to go. They're lubricated, they're moisturised. And some women will remember those deep, dark days when they used to be like that and think, goodness me, what happened? Because actually, as we age and we lose that estrogen, then the vagina tissue becomes more delicate and more friable. And then the acidity and the pH changes. And women have always got something coming out of their vaginas. So you can have that really acidic discharge sitting on that vulvovaginal tissue. And for a lot of women, what they think they've got is either recurrent thrush, or they feel like they've got a urinary infection. And actually, a lot of that has to do with the vaginal microbiome, that acidity. So what we can do when we're looking at treating women is we can also give them vaginal estrogens, and they can really help with putting that vaginal pH back to normal, making that vaginal tissue replenished and much more comfortable. And then we can add in sort of vaginal moisturiser and lubricants as an add-in just to make those more comfortable. The vagina is self-cleaning, so nobody should be using any products in there unless it's fun. And when we're looking at products we do use in the vagina, that we're looking at making sure we have the right pH, so we don't get that vaginal microbiome out of whack and cause more infections. And when the vaginal microbiome is working well and the pH is right, it's much better at self-cleaning and it fights off infections much better. So I often describe vaginal estrogens like a facial for your vagina, and something we prescribe quite regularly, and it's just a little vaginal estrogen pellet or cream that can be used. So I've hinted at some of the management strategies that we have around in terms of managing menopause. There are medical treatments. We can look at aspects around diet and exercise and lifestyle changes, but the main thing I do most of my day is manage patients with HRT, that's hormone replacement therapy. Hormone replacement therapy very quickly gets rid of hot flushes and night sweats. We've also had a new drug come to the market that's a non-hormonal version of that. It's what's called a neurokinin 3 drug, and that also stops hot flushes, but without the hormones. But for most women, estrogen is the most effective way of reducing those hot flushes and night sweats. We've talked about the vaginal aspects with that vaginal health, but also the vaginal estrogens also support the bladder, as does a systemic estrogen, to reduce those urinary symptoms, reduce UTIs, help with that urgency and that sort of nocturnal, that getting up in the night and peeing. HRT estrogen will reduce risk of osteoporosis. Estrogen regenerates bones at any age. We all know what the hormonal fluctuations are like. For those who've had PMS, PMDD, it can be really hard to see if you've had that kind of bad PMT in the past. When you hit the perimenopause, is it perimenopause or is it an exacerbation of that PMS and PMDD? And that's something we cover quite a lot in our clinic, even in younger women, is PMS and PMDD. Skin and hair, often the people get lots of skin itching, dry skin, increasing some dermatology conditions. So it's really interesting when you look at private health insurance for companies that, the amount of referrals going out for certain ages, and we're just missing the fact that actually if we looked at the hormones in the base of that, it would probably make quite a big difference. I always describe joint and muscle pains as estrogen being like oil or WD-40 for the joints. It can make a huge difference for many women. And you don't put on weight with HRT. It's one of the biggest questions I get asked in my clinic. But it can, if your body's stopping to store the estrogen, it can actually help with that visceral fat storage around the middle. But if you've always been a bum and thigh girl and then you overdo it on your HRT, it will go back on your bum and thighs, stop being around your middle. But I think the main thing to say is so many of the symptoms of physical symptoms can be relieved when we look at some hormone options. I'll cover the non-hormonal options later. There's historically been a lot of fear around hormone replacement therapy because about 20 years ago, we had a study called the WHI study. And it was actually designed to look at cardiovascular disease in women. And a lot of women weren't screened before they went in for breast cancer. Some of the women in the trial were in their 80s by the time the trial finished. And unfortunately, the trial was really badly reported. And it was one of those real sort of headlines about HRT causing breast cancer. And that really sticks in people's minds still now, both in clinical worlds and just in the media and the press. It's been really hard to debunk this. I'm going to try and kind of just run through with it to make it sound more sensible and explain it a bit more. So when we look at that chart on the left, this is the risks of breast cancer in women per 1,000 ages between 50 and 59. So 23 in 1,000 women get breast cancer, no matter what we do. And if we look at giving women HRT, so that second line, that combined hormone replacement therapy, an additional 4 women will potentially get breast cancer. Now this is quite important because this tends to be around the choice of progesterone in this HRT, so more synthetic progesterone. When women have had a hysterectomy, their risk of breast cancer goes down because they're actually only needing to have the estrogen. If you don't have a uterus, you don't need the progesterone unless you've had endometriosis. And then also that additional risk with that contraceptive pill as well, going up with that progesterone. So what this kind of shows us is actually the risk of breast cancer comes from our choice of progesterone and not the estrogen. Now, when we get to the newer HRTs we have now, then actually when we look at those, the micronized progesterones, the utrogestan, the Gepterics, actually those we've got much better safety data on, and they're not increasing the risk of breast cancer above that baseline. So they don't have that additional 4 women with that progesterone. And we've got great safety data for 5 years. We don't have to stop taking it after 5 years. That's old, outdated nonsense. We can stay on HRT for as long as we like. They can take it out of our cold, dead hands, as some of my patients will say. But actually, when we look at the other risk factors, for those who, like me, like to have a glass of wine, actually we increase our risk of breast cancer with our alcohol consumption. If you have more than 2 units of alcohol a day, that's a glass of wine or gin and tonic a day. Smoking, and actually obesity is probably the biggest risk factor we have in women. But a lot of things we can do to reduce our risk factors are looking at the choice of progesterone, exercising, and all that, the usual things around diet and exercise advice. So when we look at the reasons why women are told they can't have HRT, sometimes because of family history, there might be a history of a blood clot in the family, a family history of breast cancer. With those, that very much depends on the type of HRT. Now, if a woman's got a family history of blood clots, or even a blood clot themselves, they can still have HRT because we have newer estrogens that are given through the skin that have no clotting risk factor at all. Historically, women with migraines have been told to avoid estrogen, and that comes back to the old sort of oral estrogens that we give in contraceptive pills. And any estrogen that goes orally can be metabolized by the liver, so that's a clotting risk factor. But if we give it through the skin, we don't have those risk factors. And transdermal estrogen is very safe in that population. And in terms of too old or too young, every woman should be treated as an individual based on their medical history. So to me, there's no such thing as too old and too young. I think it's looking at that individual in front of you. Now, this is also often a really difficult conversation for women with a history of cancers, particularly breast cancers, because for those women, they'll often advise that hormones are not an option for them. For those women, it's actually should be a much more individualised discussion, exactly what type of cancer it was, at what age they had it, what their other health factors are, what other risk factors, what their management has been so far. And these women are really the women that should be managed in specialist clinics and seen by menopause specialists. I've put a link at the bottom there. This takes you to the Menopause and Cancer charity. There's an amazing woman called Danny Binnington who does some great podcasts, which gives lots of more information around menopause after cancer, because I think there's so much media around menopause. For a lot of these women who can't have hormones, they can really feel excluded out of this conversation, and it's not something they should be excluded from. It should be very much included because there's lots of things we can do for those women that's not necessarily hormonal as well, but also sometimes hormonal. So this is what I do every day, is prescribe these. We've got some various different options here. I talked earlier about those transdermal estrogens not having any clotting risk factors and going through the skin. Lots of people talk about these new body identical hormones. That's because they are, as the body expects hormones to be, they're going to be, an estradiol 17, they're not a synthetic version. The progesterone's a natural progesterone. So that's what a lot of people are looking for now, is these body identical hormones. There's still a really good role for some of the older hormones. Synthetic progesterones are much better at managing bleeding in women, particularly women with history of endometriosis, for example. They might not find those natural progesterones quite as good at managing their bleeding profile. So we've got these lovely gels and sprays and patches that women can use. But actually, if we're giving estrogen and you have a uterus, then we need to give some progesterone, because if we just give estrogen, we can just thicken endometrial lining and make bleeding worse. So therefore, that's why we give these different types of progesterone. That Utrogestan on the screen is one of the newer ones, the slightly different breast safety profile. But then we can also use things like a Mirena coil, and that doubles up as contraception. We can also just use a progesterone pill with HRT. And we've got some really good newer contraceptive pills, Claria, Zoli, which are more body identical in the estrogen. They tend to be really good for women in that kind of perimenopausal stage that want to have some contraception as well. And, Claria's actually kind of matches what the body would be doing through the month. Now, women with hysterectomy, they will often need their hormones replaced. Although some women will have their ovaries and remain, they actually tend to come to a grinding halt probably about 18 months after the uterus is removed. So they certainly need to consider hormone replacement therapy. And with those women, we also look at testosterone, particularly if the ovaries have been removed. Women with a history of endometriosis will often have a hysterectomy, but they actually also should be advised about potentially having progesterone after hysterectomy, because endometriosis is like pouring glue into the abdomen. It gives endometrial tissue in the uterus, but also goes around the bowel and the bladder. So whilst we might remove the uterus and the ovaries, there may be residual endometrial tissue around the bowel and the bladder. So we need to continue managing that with progesterone if we're giving estrogen. And then at the bottom right, that Vagifem also could be Vagirux or estriol cream. That's the one I was talking about for the vaginal health, like the facial for the vagina. There are lots of different options for those who don't want to use hormones or can't use hormones. It can take a while to find the right ones. And this is where a specialist can be really helpful to actually get the dosing right, because these drugs are used in management of menopausal symptoms, but sometimes that's not what they're used for in the rest of just of general practice. So it takes a while sometimes to find the right thing, but that's where a specialist can really go through this for those women who want to try other things apart from hormones. There is so much around diet and lifestyle that we can also do supporting hormones. I've done quite a clinical discussion today because I think there's a lot out there about diet and lifestyle and how we can manage it. But I think trying to bust some of the myths and make HRT seem much more approachable for a lot of women. I think a lot of people want to do it naturally. I also say that HRT is made from yams nowadays, so that's pretty natural to me, those sweet potatoes. The difficulty with some of the alternative therapies is we don't do huge, big randomized control trials like we do for medicines. So there's some evidence, but we don't always have great studies behind it. It doesn't say they don't work. It just means that they're just harder to get that data on. So acupuncture, hypnosis, CBT, certainly diet and lifestyle have all been, really good evidence to show they can improve some of those symptoms as well. I hope what I've done today is to give you a bit of a run through about hormone replacement therapy, some alternatives, and actually the fact that menopause and a lot of women's health symptoms just don't need to be suffered. I think this is the difficulty sometimes with access to healthcare, that, for a lot of women, it takes 7 to 10 years, for example, to get a diagnosis for endometriosis. Most polycystic ovaries is not really managed until there's any infertility problems. And I know that lots of women are struggling to get good advice and help around their menopause. We'll have lots of great resources on our website. Many companies are acknowledging that actually our private healthcare provision doesn't actually offer much in terms of women's health. So they're adding add-ons to make sure that we're covering endometriosis and polycystic ovaries, PMS and PMDD, and menopausal symptoms. We do a newsletter. We can provide on-site kind of care and packages, and we do talks across all those other subjects as well. We will see women over 18 online. What we tend to do is get women up and running on trying finding the right thing for them, and then try and get them back to their GP service as and when they're ready and when they're ready to change over. I'm hoping I've got lots of questions. I hope that was helpful. I realise I do speak quickly. I think it's from my days of being an A&E nurse and being in triage and having so many people in the waiting room to kind of make sure they were all safe. So if you have any questions, pull them over into the Slido. The Q&A code is at the bottom there, and then Palika and I will run through some of them now.
Hi everyone. In case you don't know who I am, my name's Palika Davda. I'm the Learning and Development Advisor at TMK. Thank you to everyone who submitted questions. I'm going to go through them in the order that people are liking the questions. So Lexie, our first question is, how can I support people in the workplace going through menopause and perimenopause?
I think that's a really good one. I think, firstly, looking at what your company's providing in terms of policies, menopause cafes. I think everyone's in the city, and particularly in the Lloyds network, is getting really good at this. I think just allowing the conversation, acknowledging that it's an issue. No one expects, you to be an expert, but I think there's a real element about just signposting and understanding and saying, yeah, I appreciate that you're going through this. Do you know about these resources? And just pointing some great resources that they can use, and anything internal. Anyone who's on there here, if you want to copy and paste the useful links from our website, you're more than welcome. At least they're sort of solid medical advice ones.
Brilliant, thank you. And the next one we have is, with so many symptoms, how do I know when to start linking that I'm in premenopause or perimenopause?
Yeah, this is the really difficult one, because so many of the symptoms are really insidious and vague, and they kind of creep up in women. A lot of women, and I find this in clinic a lot, don't actually know how bad they feel until they start feeling better. And we often do a symptom survey when we first see women, and that's like kind of baseline. And a lot of women I see, well, next time I see them, say, God, I wish I could do that symptom survey again, because I feel so much better and I didn't know where I was. I think for a lot of women, in this menopausal transition, a trial of treatment is a really simple thing to do. Just a 3-month trial of HRT. If they feel better, there's their answer. We will, of course, when we're looking at that, exclude other underlying symptoms, make sure it's not the thyroid, make sure it's B12, just do a full medical check before we just put everyone on hormones. But for most women, actually trying it is probably the easiest way to just see what's going on, because actually our hormone blood tests, particularly the perimenopause, don't really tell us a huge amount.
Yeah, brilliant, thank you. And the next one we have is, what advice do you have for weight loss? Is there anything to reverse hair thinning, PCOS plus probably perimenopause, after seeing your ideas in brackets?
Yeah, PCOS is a really interesting condition, and it's multifaceted as to how the body works and how those hormonal changes will work. So one, I think it's seeing someone who actually understands PCOS, a good specialist, a good gynecologist with an interest. In terms of hair loss, I think it's really important to exclude thyroid as an issue for that. For a lot of women with hair loss, it might be related to what happened 3 months ago. So if they've been under a lot of stress, just thinking that through. And then, what was the first part of that question? Sorry, it was about
It was, what advice do you have for weight loss, and is there anything to reverse hair thinning?
So weight loss, I think, is a really difficult one, because at this point, the rules have changed and nobody's told us. Essentially, you can't just eat and drink what you want anymore, and it doesn't change in a week. So actually, around the weight loss, I think we need to think a lot more in women about nutrition, and more about the nutrient content. I think women probably don't eat enough. I think they stop eating to try and manage their weight, but actually, therefore, they're not getting any nutrient value in what they're eating. We probably should be doing more weights to maintain our muscle mass, because if we've got muscles, then we start burning fat at rest, which is ideal for anyone. We want to be burning calories when we're not moving. So to me, I think it's increasing a certain amount of protein in the diet, really thinking about the nutritional value of what we're eating, and some weights and some good exercise in that. But it does become harder, and we do have to change what we're doing, what we're eating.
Yep, brilliant, thank you. That's really useful to know. The next question we have is, in a male-dominated industry, how do we make this a male issue in the workplace to ensure women are treated fairly at these stages of their lives and their careers? Ooh, big one.
I think that's a really big one. To me, I think this comes a little bit down to the private health insurance provision, because when historically, even on the NHS website, we had, for menopause, there used to be 3 or 4 pages of diet and lifestyle advice, and at the end of it would say, see your GP. And then for men with andropause, it had a sort of small paragraph and then see a specialist. And I think there's a lot around the sort of the male dominated industry, but also the inequalities in healthcare, actually in healthcare provision. So for women, you will find that actually the health insurance won't cover endometriosis, will cover diagnostics, but not any further management. Very rarely covers polycystic ovaries. Certainly, private health insurance companies class menopause as a natural process of aging, which I think is interesting, because diabetes and thyroid are hormone deficiencies, but of course they are covered by the private health insurance. And men's prostates turning into slightly hard-rolled walnuts, and the bladder issues they have around that that's not classed a natural process of aging. That gets straight to a urologist and a specialist. So there's it's a big conversation, but I think the difficulty is a lot around our healthcare provision at the start, because we've all got the same, you've all been offered private health insurance to work, but actually the offering is different for men versus women. And if women had better healthcare and better access to healthcare, we would not have half the problems we have with this in the workplace. That's my view on that.
Caroline, I think you had your hand up.
Yeah, I was just going to add something, which is just to the, and sorry, Lexie, I don't want to take your...
No, please do, jump in.
Just to add, I think key to, for me, I would respond to that answer just by adding, if we can be more inclusive of all in the workplace, including women who are going through menopause, and if you're going through menopause and you're at working age, it's going to happen at work. You're going to have symptoms at work. I think a really big thing is just understanding, if we can be inclusive, people are going to come to work and they're going to perform better. I don't know if you have any stats off the top of your head, Lexie, about sickness and menopause and people leaving the workforce during menopause. Did you touch on that?
I think it's really interesting. We lose women at the top of their game in their work, because actually they feel they can't do it anymore. And one of the biggest conversations I have in women in clinic is, do not make any big decisions until I've finished with you and this journey that we're going to go on to get either your hormones right or the other lifestyle factors right. It doesn't have to be hormones. But when women aren't sleeping and they sort of get that imposter syndrome, and sometimes I see, it's almost a bit of paranoia actually in the workplace. And I've had patients who've really blown up their lives at work and felt, and they sort of knew it was their hormones, but they couldn't explain it and they couldn't sort of make that very clear. But actually, to me, when we get this right, the city is going to look very different in 20 years, because we won't be losing those really experienced staff. They won't be leaving. They won't be cutting down their hours. They'll be staying. And it's going to look a much better picture.
Fingers crossed. Okay, so our next question is, bear with me, we've had quite a lot come through, so thank you everyone who sent them. Where was it? Okay, so I'm 28. How do I prepare for menopause? Which kind of coincides with the next question. What are the best ways to look after your hormonal health as a 20/30 something? So I'm going to combine those two.
Yeah, perfect. I think at any age we should be teaching women to understand their cycles, to understand how they are in their cycle, how they feel in their cycle. I think we have a lot of missed PMS, premenstrual syndrome, and PMDD, which is slightly more extreme, premenstrual dysphoric disorder, where for a lot of women they can feel completely different in different parts of their cycles. So they generally will feel better with a period and bleeding, and then they can have some real mood changes around what we call the luteal phase. That can be day 12 to 14, and some women that will ease off, and some women they will feel awful for that last 2 weeks of their cycle until they bleed again. And we're just not taught or educated to really think about our hormones and how they impact us and how they change our day to day. And for those PMS and PMDD, we don't always have to treat, but if we understand it, and we can treat it, we can do more about it. So actually, if we know that you're quite fatigued and your mood is quite different, and you feel very different in the week before your cycle, then actually when we start looking at planning our diaries, we can think, do you know what, I'm going to put less in my diary that week. I'll just manage my project slightly better. But actually on the week that I have my period, I'm going to be on fire. So I'm going to do more work, more exercise, but I'll be kinder to myself on this part of my cycle. So I think, one, we really need to understand our hormones, because then rather than being hindered by them, we can really harness them. They're really powerful. We can harness these and make and be better with them rather than be taken down by them. And then around the kind of preparing for menopause and how we move forward, I think the biggest thing that happens in women is we lose muscle mass and we stop moving. And the way that we work now is quite difficult. So I think that stuff you can absolutely start in your 20s, is thinking about nutrition, how you're eating, making the nutrient content really work, and maintaining that muscle mass, and just starting great habits now that will then just take you through your 30s, 40s, 50s and maintain it. Because once you've built that, it's going to be much better to manage.
I'm going to add something onto that, because I work as a PT outside of my 9 to 5. Women after the age of 50 tend to lose 1 to 2% of muscle mass a year. Sorry, I don't know if it's muscle mass or bone density. Bone density, I think. So don't be afraid to lift weights is all I'll say. And on the subject of hormones, one question we've had come through is, what would be the best way to get hormone testing? Doctors keep saying I'm too young. We don't have an age for that questioning, but
Yeah, so it's interesting. We've got some nice guidance around hormone testing. The difficulty is we don't have anything hugely helpful for hormone testing women. So if you're perimenopausal and you're having a cycle, or you're on a contraceptive pill with estrogen, actually it's very hard to measure the hormones accurately, because if you're perimenopausal with a cycle, your hormones are fluctuating hour by hour through the day. The biggest test that they tend to use in the kind of nice guidance is what's called the FSH, that's the follicle stimulating hormone. Now, if you've got a menstrual cycle, that's going to be probably normal. So the only reason I would really look at testing bloods in women is if they're under 40 and they've had no menstrual cycle, we would do 2 FSH blood tests to establish if there was a premature ovarian insufficiency. Or at the other end, for me, if you're on a Mirena coil and we want to know if you what's happening in the coil out, you need contraception if you're postmenopausal, because you'll have a raised FSH if you're postmenopausal. But the difficulty in younger women is that progesterone doesn't really tell us very much on blood tests. Estrogen's changing all the time. And so actually blood tests are not hugely helpful. They're really helpful to check your thyroid and B12, but actually sometimes trial of treatments and trying different things, because everyone responds differently to hormones. We've all had a different puberty. Some women have been pregnant, they have different experience of pregnancy. Some have different experience of their menstrual cycle, and so until we try things on women, we don't really know how they're going to respond. And I think that's the most effective way of actually just finding that individualized hormone treatment for somebody.
Thank you. And the next question we've had is, how do you know you're premenopausal if you are on the contraceptive pill, which I assume maybe can extend to other forms of contraception?
Yeah, it can be quite hard. So we've obviously got different types of contraceptive pills. We've got progesterone only pill, and then we've got a pill combined with estrogen. So we've got combined contraceptive pills. And it's, again, this is quite a big subject around contraception, because I think historically we've given out the cheapest, easiest, quickest progesterone only contraceptives, because there's a slight fear around sometimes with a combined contraceptive pill that if women are smoking or they've got slightly high BMI, then there's that kind of clotting risk factor with an oral estrogen. But actually for many women, it's a really good option having that estrogen as well as the progesterone. And then we've got some much newer contraceptives come to the market, but those can be quite slow to get through to primary care and GP clinics. So I think there's it depends whether you're on a progesterone only pill or a combined pill. But again, pills can be used when they've got estrogen in to kind of help that perimenopausal transition. The newer ones are particularly good for that.
Brilliant, thank you. So another question we've had is, testosterone has been life-changing for me, but is only available privately. Do you see this changing and more awareness and availability of testosterone on the NHS?
Yeah, so this is a really controversial one at the moment. And testosterone is currently in the NICE menopause guidance just indicated for libido in postmenopausal women. Now, this is slightly frustrating because all the 40 symptoms of menopause, libido, I can safely say for most women, is not a massive priority. They're working, they've got a lot on their plates, and sometimes libido is not a huge priority. I think the difficulty is the lack of research, the lack of data. The research that's been done so far looks at libido in women. There's a very good video on the British Menopause Society website where Nick Pano talks about the fact that actually, other women report other benefits to testosterone, but we just don't have enough data on it. So I think certainly those who work in the menopause world will see women who do feel benefits to testosterone, potentially beyond libido. But unfortunately, the current guidance, as far as the GP is concerned, it's for libido in postmenopausal women. Now, it is available on the NHS for that indication. For a lot of patients that we see, for example, we will initiate testosterone. There's the difficulty with the NHS prescribing is that you've got male preparations, and so they're much higher doses. So we're trying to give women like a sachet of testosterone and tell them to take a 1/9 of a sachet. So that makes it even harder from just a kind of usability point of view. Privately, we often prescribe Androfem. It's a female one. It comes from Australia. It comes with a syringe, so it's easy to dose. So there are options out there. There's a new menopause guidance coming out this year. I think we're all hoping there'll be a bit more in it around testosterone, and there is more data and more research going. It's a personal interest of mine. I've just been on a femtech program to look at how we can do more around the testosterone piece. So watch this space.
Thank you. We've had such a sweet question from somebody. Bear with me. Let me find it. Oh God, wait, where's the question go? Wait. Where did it go? Okay, yeah. Any advice to educate your partner? I freely talk about menopause in work. However, a male colleague messaged me for advice as he said he just wanted his wife back.
Yeah, that's quite an interesting one. I think just for the understanding of that, actually, that this is not personal. This is a hormonal transition. This is not the person who they're living with. It's not to do with them and how they're managing, but it's also just kind of pushing. And I think the difficulty with women, they might see one healthcare provider and be put off, not get the right advice first time. It's just to keep encouraging them to get to the right place and the right resources. You've got the British Menopause Society. They sort of produce all the Menopause Society guidelines for those of us who all work in sort of specialist clinics, and also for GPs as well. So there's lots of great resources on there, and that's also linked to women's health concern. But you can also look up clinics where there's British menopause specialists in those clinics that would be of help. But I also think it's really important just to see at the GP surgery, is there anyone that specialises in menopause? Has anyone got a special interest, and booking an appointment with them? But I think my general advice with women is just keep going, keep pushing, keep getting answers, and find the right practitioner for you to support you.
Okay, brilliant. Thank you. We've had a lot of questions surrounding my GP has refused to take me seriously, and I've had a lot of the symptoms that you've described. Where do I go from here, or how do I convince my GP to take me seriously?
Yeah, I think that's a really difficult one. I think part of the issue is that menopause training has not been part of medical school or nurse training for a very long time. And I mean, I spent 20 years as an A&E nurse and midwife, and nobody mentioned the word hormones. And if I could go back to being an A&E nurse and, see women presenting with palpitations and recurrent UTIs, and, I would just have a completely different approach to it. So the education is out there, it's coming. The difficulty is obviously, it's the time. They've got 10 minutes for an appointment. I think sometimes you can book a double appointment. There's some good resources you can take to actually write down your symptoms, some symptom trackers. The nice guidance is really clear that, HRT, hormone replacement therapy is the first line of treatment, and the symptoms that's associated with. This is why, we end up seeing patients. We often will see them initiate treatment and then write to their GPs and help advocate and signpost and get their prescription on the NHS ultimately. But I appreciate it is a really difficult thing to navigate out there with the current health system, which is really under stress.
Brilliant, thank you. For anyone who wants to send in a question, just to let you know, you can also send Carrie-Anne, our head of I&D, questions too. Okay, the next question we have is, amongst other symptoms, I have vertigo. Is this a common symptom?
It is actually. Vertigo, migraines, all really common. Sometimes will be quite cyclical, sometimes will be ongoing. Again, I think it's always really interesting. I do think as women we need to look at everything, and I'm always very cautious when I'm doing consultations to really take a full history, excluding other underlying causes, make sure it's nothing else that's causing those symptoms, and then yes, it is an interesting one. I see a lot in clinic that vertigo can improve. Same with tinnitus, oddly, and that plantar fasciitis and dry eyes. So all sort of really random things that you necessarily wouldn't always think. But we've got to remember we've got hormone receptors in pretty much all parts of our body. So yeah. It would impact multiple areas.
Everything relates to everything. And one more question, Ari, symptoms. I'm constantly knackered. How can I get more energy? I think a lot of people watching can relate to that one.
Yeah, I think we're working long hours. We don't see enough daylight. We haven't had a particularly great summer for those of us who are in the UK. We should all probably be taking vitamin D supplements. And I think that's something we certainly miss out on. I think, again, a lot of it comes down to nutrition and, eating on the go, think about what we're eating, exercise, all that's the usual sort of self-care that, that we have to do. But also just actually really sensibly underlying, exclude underlying causes. Is your thyroid okay? Is your B12 okay? I mean, hopefully, because most of you are in the city and insurance, you'll have yearly medicals or some sort of access to some healthcare provision. Use them, absolutely use them, and to make sure that you're kind of checking on your health.
Brilliant, thank you. A very specific question here. I'm about to have a hysterectomy. I'm on sorry if I mispronounce any of this. Estrologinal gel, 4 pumps a day, and have Mirena coil. Can I keep taking my estradiol gel? For those who are watching, I have dyslexia, bear with me. And do I need to have a progesterone after?
Sorry. Afterwards. So I was going to say I'm going to give general advice because I can't give exact advice without knowing somebody's medical history. But yes, you can absolutely keep taking estradiol all the way through to surgery. Again, some people have stopped on their HRT because the old oral estrogens would have been a clotting risk factor post-surgery. But using a transdermal estrogen like that gel, it's absolutely fine to keep taking all the way up to surgery and all the way through the other side. If the hysterectomy is, I don't know what the hysterectomy is for. Mostly, yes, you just need estrogen after hysterectomy. But as I mentioned earlier, women with a history of endometriosis, we would probably give progesterone too after the surgery if we think there's any potential residual endometrial tissue. I hope that kind of answers that question.
Thank you. We've got about 4 more questions left, and just be mindful of time. One more question. Does menopause have any effect or correlation to UTIs? Never had them before, but now I'm having them frequently.
Yes. So without estrogen, estrogen works on the bladder trigone, so the mechanism to release urine, the urge to pass urine, and actually our urethra shortens, and then we've got all that sort of vaginal pH changes as well. Our anatomy is very close together. So yes, recurrent UTIs is a really common thing we see. We can manage them with vaginal estrogens. That can make a huge difference just on their own, just vaginal kind of treatment, and or systemic AHRT as well.
Okay, cool. I think we have a question for Carrie-Anne. Does Tokyo Marine Kiln have any good initiative around women's health and wait, sorry, that's now gone to the top. Bear with me, the Slido's moving a lot. Sorry, does Tokyo Marine have any good initiatives for menopause that other organisations can follow?
Thank you. Yes, we do. So we have a menopause policy that was written in partnership with our menopause network, which is a subgroup of our gender network. If you don't have a menopause network, I would really suggest setting one up. Finding out if there's interest, if there's people that want to join and want to lead, and setting one up. I think our menopause network is one of our most active. Menopause networks helps because people know what being perimenopausal and menopausal is like and actually know what they need at work. So it's a great group to consult with, but it's also fantastic for peer support because it's a place where you can go and sit down and say, well, you know, this is what I'm going through this week or this month or today, and share stories with each other. I actually have tinnitus right now. And so because when I'm stressed, my ears just start to sting, which is a thing I'm getting now. And even just people talking about that and knowing that just helps. It just helps reduce the stigma a little bit. I also think once people start talking about menopause at work, because there's a policy there, it just makes it easier to talk about menopause. The more people that mention it and talk about it and say the word menopause, the easier it is for us to make our own adjustments for the things that we need or ask others. Does that answer the question?
And also TMK have provided their employees with access to our service. So they actually purchased a bulk of appointments of first and follow-ups. So the employees could actually just book their appointments with us, have access to the service paid for by TMK. So I mean, that's been really well received by your employees, hasn't it?
Yeah, and I would say just from my own experience that I mentioned earlier, I didn't know that you could get specific specialist advice at the beginning of my journey, and I think things would have been a lot easier for me if they were. So if you're listening and this is you and you're not sure and you've been told like I was by my GP, it's perimenopause, we're not going to test you for anything, you're too young, just put up with it. You know, if your instinct is to push on that, then take it from me, definitely should.
Thank you. And we had a question, I think, just generally for the Dive-In team. I'm asking if the recording would be shared. So the recording for the session will be uploaded on the Dive-In platform sometime after the session ends. So keep an eye on the website. Is all the information we have at the moment. Not a question, but menopause policy, brilliant. And someone said, bear with me, thank you for all the advice you provided during the session. It was really interesting and useful. I think we are down to our last 2 questions. Let me try and find them. Right. So does menopause have any, where was it? Oh, right. I'm not in a relationship. So libido related symptoms aren't being considered when looking at potential testosterone requirements. How can I overcome this?
Yeah, it's a really difficult one, this one. I think there's an element of guidance, but I think, we do know that other women report other benefits to testosterone, and we're hoping that some better data and guidance comes through. I think it's if we think about libido as a word, that's an interesting thing to do, because actually, does libido mean sexual libido, or does it actually mean life libido? And so I think sometimes if we look at the wording, that's an interesting way to interpret that.
Okay, brilliant, thank you. Just checking for any questions that I might have missed. Okay, I get cramps in my abdomen about a week before my period and really bad when running. Is this hormone related? Any treatment suggestions for this?
I would say I'd like someone to have an examination in that case and see, use your if you've got access to private healthcare, use your private healthcare, see a gynecologist. Anything in women that is impacting life, pain, cramping. Again, I see lots of women in clinic and they just say, I didn't know having to take painkillers 3 or 4 times a day was normal. Yeah. I just thought everyone else was doing it. Any sort of heavy menstrual bleeding, any flooding through, any pain, any discomfort, that's where we need to actually see women. And we can rule out lots of things, but also it's a great point to have a conversation just about our general reproductive menstrual health and check in.
Thank you. And another question we have is, how would I know if it's a hormone imbalance that's causing feelings of depression a week before my period?
There's some really great resources when you look at the National Association of Premenstrual Disorder. It's called NAPS, and the International and IAPMD as well. The links will be on our website. There's a whole section on PMS and PMDD, and there's a lot around tracking. There's some great apps that you can use for tracking, or you can just use a diary. But understanding that relationship between mood and the pre-cycle is really helpful, because either we can find other ways to manage it, or just to know that it's there. It's just a point of, I'm not going to make a decision this week. I'm going to park that till next week. But actually, we also have a lot of really effective treatment for PMS and PMDD now, and ways to manage it if it's becoming really life impacting.
Thank you. And I think our last question is, what type of physician should someone see to discuss menopause? A specialist? ?
Ideally, the difficulty is there's not many of us out there. So I think I'm one of about 10 to 15 nurses who work at this level across the whole of the UK. There are more and more GPs specialising in menopause. Obstetricians, gynecologists may have an interest in menopause. I think the difficulty is we don't have a specialist area for women's health, and that's really what we want to be aiming for in the next couple of years, that we actually just have women's health hubs with experts in all these different fields of women's health who know what they're talking about in great detail, rather than a sort of more generalist approach to women's healthcare that we currently have. So I think word of mouth recommendation, depending what country you're in, look at the Menopause Society for that country that you're in. They'll have a lot of resources. They'll have probably links to clinicians. If you're in the US, you've got the North American Menopause Society. We've just changed their name just to make it really unhelpful for me. We've got the International Menopause Society. We've got the British Menopause Society. So those kind of societies will probably be the best links to find the right practitioners. And those are the ones that normally organise most of the training as well in those local areas.
Brilliant, thank you. We've got one more question, and then I'll hand over to both of you to wrap up. I have had PCOS in my 20s and my hair thinned. It seems to be getting worse now, and I'm on estradiol. Sorry if I mispronounced that. Is there anything else I can do?
Yes, I think just having a review with somebody who can understand a bit more about PCOS. There's a lot around PCOS in terms of other medical factors that we need to look at. So yes, seek out some more expert advice. There's a great website again for PCOS on ours, a great charity website. Same for endometriosis. So just seek more advice and guidance, but don't just put up with it, and keep going.
Thank you. And that's all the questions we have. Sorry if I missed any questions that were sent through, and thank you to everyone that did send them through.
Thank you, everyone.
Thank you, everyone. Thank you.
Would like to speak to me about our menopause policy and our lessons learned, things like that, then you can reach out to me at Tokyo Marine Kiln if you know me. I'm also on LinkedIn.
Same, I'm on LinkedIn. Always happy to have a conversation, and I hope that was helpful. Thanks very much.
Thank you.